Good morning. I'm Chris Murray from the Institute for Health Metrics and Evaluation at the University of Washington. And the way this is going to be structured is I'm going to first pass over to Sam Kass from the White House, and then I'll do a little presentation, and then I will pass over to Howard Bauchner, the editor of JAMA. Let me introduce Sam Kass, who is the executive director of the Let's Move program and senior advisor on nutrition.
Good morning. Thank you, Chris and Howard, for being here and having us here. This is a pretty important day in our world. So since the First Lady has come to the White House, she spent a huge amount of her time and energy there working to unite around the country around our family's health. And today we are reminded why that's just so critical for the future of our country. During the past 4 decades, child obesity rates have tripled, with nearly 1 in 3 kids in our country overweight or obese. Those same kids are on track to a future where 1 in 3 Americans in this country will have diabetes if we don't significantly change course. And this is taking a huge toll on our country. Right now, we're currently spending $190 billion a year treating obesity-related conditions. But when you project out where we're headed, that number is set to absolutely skyrocket. This is also seeing the impacts on our economy and our productivity in our education system, where kids who aren't getting the activity they need are performing lower on math and reading comprehension tests. And even our national security is starting to come into question. We hear from our 4-star generals that obesity is now one of the greatest threats to our national security, with 27% of 17 through 24-year-olds unable to pass the test to make it into our national armed forces. And it's also the #1 reason for disqualification for military service once our troops are in active duty. So the First Lady launched Let's Move to really bring together the country to dedicate our efforts to solving this challenge. And over the past 3 years, we've seen some incredible progress. Working on in schools, getting our kids more active, improving access to healthy, affordable food, improving childcare and childcare programs and get our kids off to a healthy start, and really working with the private sector to make some real progress. So today's reports and findings by the Institute of Health Metrics and Evaluation underscore just how important all these efforts are. Today we learn that dietary risk factors are the largest driver of chronic disease in the United States. Let me repeat that. Diet is the largest driver of preventable disease, of chronic disease that we face. Dietary risk factors account for 670,000 deaths each year, 1 in 4 deaths annually. So this adds up to 9.7 million healthy years of life lost due to poor nutrition. That is staggering. Too little fruits, vegetables, whole grains, nuts and seeds, too much processed foods, sugary drinks, and sodium are severely reducing the quality of life for Americans. And insufficient physical activity was also identified as the 6th leading cause of disease burden in the United States. That adds up to 234,000 deaths each year. This data, compiled with the current child obesity epidemic, shows that the stakes really could not be higher for our country to solve these challenges. But we are definitely moving in the right direction. As today's report shows, we're making progress on becoming a more active nation. In fact, some counties increased physical activity as much as 15% over the last decade. But we need to continue to work together to support communities to be more active, to have better access to parks and playgrounds and bike trails, and more opportunities for children to be active in their schools. And we're seeing progress on many other levels. Last year, we saw fruit and vegetable consumption increase by 6%. We're seeing sugary drink consumption decline. We're seeing tremendous progress in our schools with the implementation of better school lunches. The USDA just released the Smart Snack Rule to make sure that all food sold in schools are of highest nutritional value, and we're getting our kids more active through the Let's Move Active Schools program. We know we have to make it easy for families to live healthier lives. So later on today, Chris and the Institute of Medicine will join the First Lady at the White House to brief mayors and other elected officials on this report's findings in a special convening that the First Lady is hosting for her Let's Move Cities and Towns and Counties initiative. This initiative calls upon and works with and supports local elected officials to adopt long-term, sustainable approaches to addressing these challenges. We know that sustainable solutions will not be the same for every county or every city. By providing elected officials with this kind of detail and this kind of data, right down to the county level, elected officials can tailor their strategies and track their own progress to meet the needs of their communities. So I would like to thank this incredible team of researchers for continuing to gather this science and data that drives our work every single day. This report lays the foundation for what many of us work to develop the strategies and initiatives around. This is our foundation. This is a bedrock. It reminds us how great the toll that poor nutrition has on our country, from our economy to our healthcare system, to our education, to our national security. But it also reminds us the toll it's taking on the quality of life of Americans, the number of years of quality, healthy years that Americans are living. I know this problem is one that we will solve. There's just too much at stake. Let this report be a massive call to action to redouble our efforts to make meaningful, sustainable progress to solving these challenges. It's going to take bold leadership, both from individuals in their homes, to community leaders, to business leaders, and to government officials, if we're going to successfully forge the future that our children so richly deserve. So thank you.
So now what I'm going to do is briefly discuss some of the key findings in the analysis published today in the Journal of the American Medical Association called The State of U.S. Health, and in the two companion publications in Population Health Metrics on county-level patterns. And I think the fundamental theme is what Sam Kass just mentioned, that through the analysis of the state of the U.S. health, we identify a number of potential avenues for improving health. And by looking at local experience, we actually find communities in the U.S. where there is tangible progress, meaning that there is both the potential and the reality for a substantial health improvement. The U.S. Burden of Disease Study, the State of the U.S. Health Study, is the work of a large number of collaborators and has a lot of detail to help us unpack what's happening to health in the last 2 decades. We can't avoid the observation to start with that the U.S. spends the most on healthcare and actually gets relatively mediocre outcomes compared to other nations. But having said that, what we're going to find as we drill down into the detail is that there's examples where the U.S. does rather well, and there's examples where we've seen real progress in the last 20 years, and there's examples where there's still room to move, and I'll come to that. Now, what I'd like to use is a series of live tools that have now gone live on the internet to help explore what is shown in 2 dimensions in the scientific journal articles and in the summary policy report. So let me start with familiar territory, which is what are the leading causes of death, but rather than counting death numbers, talk about the premature mortality. And that's by basically saying if you die at a younger age, you've lost much more of your potential life. And this diagram, which I'm just going to try to make a little bit bigger so you can see, shows you the leading causes of premature mortality in 1990 and the leading causes of premature mortality in 2010. It's the same as what shows up in the JAMA piece. And what it demonstrates is that some of the leading causes, like ischemic heart disease, that's heart attacks, have gone down more than 20% in terms of numbers and in terms of rates even more, but still remain as dominant causes. And that'll feed back into what Sam Kass said about diet in a moment. Other leading causes are things like lung cancer, stroke, or chronic obstructive pulmonary disease. But by looking at premature mortality, we also have road traffic injuries and suicide in the top. Another observation is that related to the obesity epidemic, we believe, diabetes is shot up to the number 7 cause, and chronic kidney disease has gone up to the 16th cause. Other upswings that we should pay attention to are Alzheimer's, the rise up to the 9th cause of premature death, as well as the rise of cirrhosis and drug use disorders. At the same time, there's these success stories in the US, the big drops in HIV, and I think Howard Bauchner will talk a little bit more about other success stories in his comments. So that's the sort of first look, but if we take into account that health is more than simply avoiding death, it's actually being healthy, and we look at the construct of healthy years, or what we call disability-adjusted life years, this is the pie chart. It's a square pie chart that we can see for the US, and it shows the big contributors: heart disease, cancer, mental disorders, bone and joint disease, diabetes, chronic respiratory disease, neurological disorders, all shown in blue, and then the injuries in green, and then the neonatal causes and some of the infectious causes shown in red. And of course, for those who are interested, you can drill down to more detail and see very specific causes in this view of what are the main contributors, what are the leading cancers, what are the leading causes of heart disease. So ischemic heart disease, depression, chronic obstructive pulmonary disease, low back pain, these are all major contributors to overall burden in the US. Useful diagnostic for where we are, and you can also see by the dark shading in this which causes are going up over time. So Alzheimer's is going up, depression, kidney cancer, atrial fibrillation, examples of rising shares of the burden of disease. I think perhaps it gets the most interesting when we look at the contributors to the risk factors. And so what's an important insight in the analysis here for the United States is what are the leading environmental, behavioral, and metabolic risks that account for the pattern of disease in the United States. And the number one risk is this amalgamation of 14 components of diet that says it's the leading risk factor in the United States for both mortality but also for healthy life years. The number 2 risk is smoking. The number 3 risk is obesity, up from the past. The number 4 risk is high blood sugar, and then we see physical inactivity, and we see alcohol use, rounding out that top 6 set of causes. So a surprise to many of us in terms of the magnitude of diet, as well as the rising importance of obesity in accounting for the patterns that we see. So if you compare the US across countries, we find that the US does well for some outcomes like stroke or colon cancer or breast cancer, and for many outcomes has higher rates than other countries. And we can trace that back, for example, higher rates of heart disease, to diet and obesity. And so in companion work, we've tried to look at the county level at some of these key contributors to ill health in the United States. So let's start first by the story around county life expectancy. Now, I think this is probably something that many of you have heard about before, but let me just show you the story of the last generation of life expectancy change at the county level. So this is for women, and so we're slowly watching life expectancy change county by county. You'll see parts of the Middle East turning blue. That means higher life expectancies out west, in California, along the Texas border. You'll see up in New England increases in life expectancy. But you'll also see areas in Oklahoma and Mississippi and Alabama where life expectancy hasn't changed, and in fact, for men, stayed pretty constant. If we look for women, it turns out that there's actually places in the United States where life expectancy stagnated or went down, so that we now have a widening span. Now, why is this important? First of all, those communities are places we may want to target some of the public health and cross-sectoral actions that we've spoken about. But the success stories in improving life expectancy in some communities tell us that change within the U.S., within the U.S. health system, is possible. For example, there have been increases of more than 10 years in places like New York or San Francisco, but take a look in Beaufort County in South Carolina, where life expectancy has improved really quite substantially over that period of time. And there's many examples like that around the country. You can see that more directly in these tools by looking at change. And when we zoom out and look at change in life expectancy, you can see that in a line from Oklahoma to West Virginia, there has been little progress for women, but there's many communities in Louisiana and Georgia and South Carolina that previously had very low life expectancy that we're seeing real progress. So there's success stories within the country that tell us that it is possible to make progress for women, and for men, progress has even been more substantial. We're also able, because of the Behavioral Risk Factor Surveillance Survey and the investment in collecting that data, we're able to look at patterns of two of the key risks that we see in the State of the U.S. Health Study, namely obesity and physical activity. So let's start with physical activity. This is for women back in 2001. And here's the story where I'm showing the percent by county of sufficient physical activity. That's 150 minutes a week of either moderate or vigorous activity. And red is low, and blue are the groups that are up in the 70% or so. And watch what happens in the United States, which is, here's an example where over time we're seeing higher levels of physical activity in many places. And you may not actually see in the change quite how dramatic those improvements are. So I'm going to change the map to show change in physical activity. And now the blues are places where we've seen increases over 10 percentage points. And in the highest level, in Morgan County, Kentucky, we've seen an 18 percentage point increase over the decade in physical activity levels. So pretty dramatic progress. Kentucky, parts of Georgia, Florida, North and South Carolina, parts of Texas, and in a number of other communities that you can see in dark blue. So real progress in improving levels of physical activity. I think as researchers, we were really quite surprised by this, and given what we've seen in the State of the U.S. Health Study in JAMA, has enormous health benefits in its own right. Now, when we do the same sort of analysis for obesity, and again, looking at women, the story will be similar for men, a little bit lower. The story is a little bit different than for physical activity. We're seeing the spread over the last decade, continued spread of obesity outside of into many parts of the country, with the residual parts of the country with less than 20% obesity really in Colorado and Wyoming, western Montana, San Francisco, New York, a few places in Florida. And we're seeing rising obesity. Now, there are still, as we saw for physical activity, huge variation across communities. And I'm going to switch to looking at change. The communities shown in blue, the increase in obesity has been minimal over the last decade, and the communities shown in red, there have been quite substantial increases. And so although we haven't seen reductions in obesity, we've seen some communities that have been able to hold back the rise that we've been observing in the decades prior. And I think that's also an indicative that we're at the point now where some communities have been able to stop increases, or at least keep them to a minimal level. And combined with some of the other knowledge that we're seeing coming out of these analyses around physical activity, the importance of diet, adds to this theme that there's quite substantial potential for improvement. Our take of the main study in JAMA on the state of the U.S. health and these companion analyses of county trends is that we've identified substantial areas where the U.S. can make progress and hopefully narrow the gap between what we've observed in the U.S. and other OECD countries. Diet, tobacco, physical activity are areas where community intervention can work, and I think there's real potential there. There's also a role, we believe, for enhanced primary care, management of blood pressure, cholesterol, encouragement of physical activity of patients that should also be part of the story about how we see better outcomes in the U.S. And lastly, I think is our theme that information is empowering to communities, that by tracking what's happening in detail for each locality, local leaders then have the tools at hand to both figure out what's important in their communities and figure out if the various strategies they're using are actually having an impact. And so one of our key messages for the future is the importance of continuing the government investment in data collection and perhaps enhancing it, and also continuing the effort to track outcomes at a fine-grained level. So I'll pass over now to Howard Bauchner from JAMA for his own comments.
Thanks, Chris. I'll keep my comments short because I think probably questions and answers will be more interesting. So this paper arrived at JAMA on May 1st, 10 weeks ago. Chris and I had talked about it. We get about 4,500 papers a year. We publish 200. There's thousands and thousands of papers published in the medical literature each year. There's a handful of landmark papers. I can't congratulate Chris and his 100-plus co-authors with more enthusiasm about this work. It's been years in progress. There's been other reports, but this is the first comprehensive box score of American health that's ever been published. It's an extraordinary publication, and I really want to congratulate Chris and his many colleagues. It's a unique box score because it not only compares the United States to itself between 1990 and 2010, but it also compares the United States to 34 OECD countries, or all 34 OECD countries are compared. And so you can see the rankings of how well the U.S. has done, both in terms of progress as well as where we stand in 2010. The other strength of the paper is it doesn't concentrate only on mortality. We've learned more and more in healthcare over the last 2 or 3 decades that morbidity or disability is an important component of health. And one of the unique aspects of this paper was that Chris and his colleagues actually questioned or polled 10,000 U.S. citizens about what was important to them with respect to disability. That's a very, very unique contribution. So Chris gave you different types of data. It's detailed in the paper, but there's both mortality and morbidity information. And I think that's the other unique aspect of the paper. So where's the progress been? Between 1990 and 2010, the progress for HIV/AIDS is an extraordinary accomplishment. It's a tribute to both scientists, clinicians, and the HIV/AIDS community that was very, very active in pushing the research agenda over the last 20 years. But in virtually all of the data figures, mortality, morbidity, disability, HIV/AIDS has declined tremendously over the last 2 decades. Remarkable progress in ischemic heart disease. But unfortunately, since it's so common, it's still a major contributor to both mortality and to morbidity. Specific cancers, breast, colon, trachea, bronchus, and lung, you've seen tremendous reductions in morbidity and mortality. As a pediatrician, for me, it was wonderful to see the virtual elimination of Haemophilus influenza type B disease and a decline in sudden infant deaths from about 6,000 deaths to about 1,500 deaths over the last 20 years. So those have been the areas of great gains. Challenges. Alzheimer's, I think it's been well reported. The aging population, what appears to be an increase in the possible prevalence or incidence of Alzheimer's disease. We've already outlined in JAMA a number of times about the epidemic of opiate use in the United States. And so that remains a confusing issue in terms of how to approach patients around pain control, but not to oversubscribe opioids. Mental and behavioral disorders continue to account for a great deal of morbidity in the United States. And then lastly, the rise of diabetes, which has obviously accompanied the obesity increases. Chris clearly outlined a number of the major risk factors. The U.S. has done relatively well in comparison to many of the other OECD countries with respect to tobacco. The Surgeon General's 50th anniversary is coming up next year. It is one of the areas where the U.S. has done as well, if not better, than many other countries. But I know under Secretaries Sebelius and Howard Koh, there's still a great deal of progress to be made around tobacco smoke. Some of this is played out in New York City. It's been very interesting to see how the mayor has approached that issue. He clearly believes that public health is an important approach to improving the health and well-being of citizens in New York City. Cholesterol, BMI, high blood pressure, I think many of you recognize, untreated, unrecognized hypertension remains an issue in the U.S. The CDC, the NIH, many of the cardiology societies have made that an important initiative. The American Medical Association has endorsed hypertension and obesity as two of the major areas that they're going to focus on in the coming 5 or 6 years. When the paper came in, because it was so unique, we handled it a bit differently than other papers. So it was both internally and externally reviewed like all papers, but I orchestrated the external review, which is somewhat unusual because I don't handle that many papers, but we recognized, one, how important the paper was, but in addition, the speed with which we needed to move so that it could be published on July 10th. And in the peer review process, there were a number of concerns that were raised about the paper. And I think Dr. Feinberg, in the accompanying editorial, talks about some of the challenges in the paper. So we can't forget that poverty drives healthcare. And so outside of the realm of what was considered in this paper are the so-called social determinants of health. And I know that Chris and the co-authors recognize it, but because of the structure and the way in which they were looking at data and the amount of data that links social determinants to health in a causal manner are far more complicated, that was not considered in the paper. And Dr. Feinberg in the accompanying editorial points that out as being an important part of understanding health in the United States. The other issue that arose in the peer review process was the complicated discussion about diet. So we know many aspects of diet that will improve health, but they're very, very interrelated. And so it's very hard to tease out just 14 individual components. So when I look at what I eat at dinner, I don't go, oh, it's this component 1, this component 2. I'm eating an entire meal. And so the dietary data are still complicated. I know Chris, and particularly Darius Massa-Ferrarian and others, are working on additional papers that will provide additional information about the dietary components that they looked at. Dr. Feinberg in the editorial describes this as a Herculean effort, one that will transform our understanding of health in the United States and how well we do in comparison to other countries. And I just really want to close by once again congratulating Chris and his co-authors. And for us at JAMA, it's really a privilege to have published this paper. As I said, there's a handful of landmark papers that are published each year in the medical literature, and this is certainly one of them. Thanks, Chris.
So we're open to questions, and I know that Sam Kass has to head back to the White House, so won't be fielding questions, but I'm happy to, and Howard, I'm sure, will be happy to as well. So Rhonda has a microphone, so questions? Hopefully, somebody. Yep, there we go.
Is it on now? Chris Flavelle from Bloomberg View. I'm struck by the idea that activity has increased, but so has obesity. Is that a function of perhaps different people increasing their activity from those who are more obese? How do you explain those two things moving in what seems like different directions at the same time?
So, great question. I would make the following reflections on that. The county analysis that I was showing is at the community level. It's using the Behavioral Risk Factor Surveillance Survey. So we're not able to link the obesity to the, or at least in this analysis, that's not what we've done. I think when we tested statistically the relationship between change in physical activity and change in obesity, there is a relationship. So those places that had more physical activity had smaller increases in obesity than you would have expected. So if the general trend wasn't up, you would have actually seen obesity go down in those places. Now that relationship is not enormously strong. For every percentage point increase in those meeting the 150 minutes a week criteria, obesity is about 0.1% lower. So I think the answer on that is that to tackle obesity probably requires more than, at the community level, more than the pursuit of increased physical activity. It probably also requires changing caloric intake.
Scott Hensley, NPR. I had a question about success stories. I assumed it was on when she handed it to Wise Guy. I had a question about the success stories. It seemed that the examples that you mentioned were driven largely by pharmaceuticals, HIV, cholesterol reduction, and vaccines in the case of the Haemophilus. How much then are some of these problems about pharmaceutical or treatment innovations versus policy changes?
So I think that's a good question. Howard may also want to comment on that. If you look at the success story around ischemic heart disease, I think that's a mixture of both better direct intervention, pharmaceuticals, but probably also direct acute intervention around cardiac events. But it's also a change in some of the underlying risks, like a decline in tobacco consumption. And so that's not a pharmaceutical. So I think a big driver of some of the trends we've seen has been in men dropping tobacco consumption for a number of decades. And now perhaps the reason that progress on women or the lack of progress seems to be turning is perhaps that the effects of tobacco have peaked in women perhaps 3-4 years ago in terms of what we see in lung cancer rates. I think if you look at success stories around physical activity, there's clearly communities that have raised physical activity, and that's also not pharmaceutical related. But my interpretation, I'd be interested in Howard's, is it's a mixture of where there's been very targeted interventions, the Haemophilus influenza example, but take SIDS. SIDS was not a pharmaceutical. That was a public information campaign. And I think it demonstrates how information and the right message and motivated citizens and parents can actually make a big difference. But Howard?
Like most answers, it's a blended response. Chris is right. Sudden infant death syndrome was the back to sleep campaign. You go from 6,000 deaths a year to 1,500. Haemophilus influenza type B is an extraordinary accomplishment. 20,000 cases a year now, a couple hundred of invasive cases, not deaths. My cardiology colleagues would say around ischemic heart disease, it's statins, other treatments, other invasive treatments that they've gotten good at, coronary artery bypass, percutaneous treatments for cardiac events, beta blockers when necessary, and some improvement in lifestyle. Don't forget, we think the obesity epidemic is cresting. So the 2010 data, okay, it will be interesting. I asked Chris if he was when he's going to report out the 2020 data. But for me, what will really be interesting is because of the First Lady's campaign and other people's real acknowledgement of the cost of obesity and lifestyle and physical activity in terms of healthcare, it will really be interesting to see the data over the next decade, because I don't think that impact you would have seen it reflected in the 2010 data, the emphasis on physical activity and obesity. I think that's yet to come. The oncology world is very interesting. Colon cancer probably relates to appropriate screening and then follow up in treatment. So there it's probably very carefully tied to both what's been recommended by the task force, different oncologic societies, as well as then treatment. Breast cancer is probably both a screening for mammography and then much more appropriate treatments. So there I think it's both a mix of screening through primary care and then appropriate treatments. So it's going to vary from condition to condition or disease to disease.
Hi, Amy with CBS. One of your maps showed a red area on the Mississippi River, and it didn't show like the whole state being red, but just that cluster, the area on the Mississippi River. Is there a significance to that? Did you guys look into a reason for that at all?
This is the one you're talking about, life expectancy? You know, there's quite a literature about this. I mean, this is a phenomenon where some of the lowest life expectancies in the U.S., at least for a couple of decades, have been known to cluster in the lower Mississippi Basin and the Delta area. And I think nobody's got a simple answer. I don't think it's environmental, if that's what was behind your question. It really seems to be a combination of poverty, as Howard was talking about, but also some of the classic risks that we're talking about: high obesity rates, low physical activity, high cholesterol, high blood pressure. So all the key determinants turn out to be bad there. You can ask the sort of higher order question, historically, why? I think on the good news front is that if you look here, zoom in a little bit into the area around there, some of those communities have actually seen progress. And if I just switch to the change view, you'll see that there is actually some communities a little bit and that would have been low have actually started to see improvements. So maybe some of that begins to change. Oh, over here, sorry.
Sabrina, is it on? Sabrina Tavernisi, New York Times. Could you sharpen or elaborate a little bit? You mentioned diet was overtaking smoking as sort of a main cause of preventable death, unless I misunderstood, but kind of talk about the difference between diet and smoking, because I know there's some debate about whether, how much preventable death obesity is actually causing.
So here's the chart, and it's in the JAMA paper, where we look at both deaths that are attributable to leading risks and also disability-adjusted life years, the measure of, the more comprehensive measure of health. And in both cases, diet, in our analysis, which is based on the 14 components, is a larger contributor in terms of attributable burden than smoking. They're both huge. So I think, the fact that it's a little bit bigger, I think, is probably less the issue than the
Overall deaths or just the burden?
Both for deaths and both for DALYs. I can switch the view here. Let me just toggle this to deaths, and you'll see that. And I'll just make this a little bit so you can see the scale. And if we put numbers here on the bottom, you'll see that diet is still larger than smoking in terms of deaths. And then if you switch over to DALYs, again, you'll see a pretty similar story. So very surprising to us, but I think it's an important aspect of the finding. I think the reason we see this, that we didn't see that in the past, is that previous assessments like this only looked at fruit and vegetable intake. And then other assessments looked at sodium. And what we've done is we've put together these different subcomponents. I can show you those here on the subcomponents, where we've got these 14 subcomponents that's yet to be published, the subcomponent analysis. But it's shown here in terms of what makes up that diet composition. And that's low fruit intake, low nuts and seeds, high sodium, high processed meat, low vegetables, high trans fat are the top contributors in this list.
Is at what point in time did it actually cross over to become more? At what point in time did it actually cross over to become more of a problem than smoking?
Well, it probably was for even back in 1990. Now, that's for both sexes combined. And so tobacco's going down in men, the burden, and going up in women. So there's a little bit of that dimension. But I think what's new here is not that diet has gone up so much as that we now have got quite a lot more evidence that's gone into this and synthesized. You know, the meta-analyses on each of these components, some of them were only published quite recently to get incorporated. So it's more the sort of science has advanced around it, and we now have a somewhat better understanding of the total contribution of diet. Given the importance of, I mean, I can show you, we've experimented in ways to show these relationships. Let me show you one that I think may help get at this, which here's the pie chart of what we call a tree map of different diseases. And now I'm going to show you the attributable fraction for diet. So what this shows is the fraction of each of the diseases that's attributable as the dark shading due to diet. So a big fraction of ischemic heart disease could be traceable to diet of ischemic heart disease, but some cancers, lung cancer, colorectal, stomach cancer, some components of hypertensive heart disease, diabetes, and CKD. So it's a way to visualize where each of those pairs, there's convincing or probable evidence that the relationship holds for diet. I don't know if that helps get at what you were asking. All right, there, and then over to here. Yeah.
Pat Sullivan, Washington Post. I'm curious about a comment that the JAMA editor made, that you think that the obesity crisis is cresting. What kind of data do you have to show that?
There's been a number of papers published, of which a couple have been in JAMA, that have suggested that it may be cresting somewhere around, I mean, Chris may know the data even more accurately than I, somewhere between 2010, 2012. I mean, the CDC is very good about doing yearly or biannual surveys. And so I think there's been so much attention placed on the obesity epidemic that I'm guardedly optimistic that individuals, communities, employers are listening, and people are really recognizing the importance of healthier diets and reducing their weight. So I think the data are pretty substantial. It's certainly not growing at the same rate that it grew between 2005 and 2010. And as I said, we had published a paper or two earlier this year that suggested that it had finally begun to crest.
Question over here.
Alicia Alt with Internal Medicine News. Excuse me. Is it possible that there's a really simple message here that diet, exercise, and smoking are basically the three biggest things you could pay attention to for your health? A message that physicians could give patients and a message for the general public.
Yes, but I would add to that, especially for physicians, that management of blood pressure and cholesterol in the primary care setting is also a pretty key component. And then the only other thing I would add there is, given the rising burden of disability in this country from musculoskeletal disorders and from mental disorders and substance abuse, paying attention to your patients that have those is also really important. But on the premature mortality side, I would agree with that summary.
Would you say that your study has given even more evidence that these components are very important to every aspect of health?
Sure, I think that's right. Howard?
Well, the one comment I would make, I think people who followed the IOM report on salt recognize the way in which the IOM report was written and articulated was a less precise view of different levels of salt. And people are struggling when you give public health messages, whether or not you can make them, whether they should be straightforward and simple, reduce your salt to X milligrams per day, versus saying it's just better if it's lower. This is a really complicated and controversial area about how to communicate health information to the public at large. I would say in response, I think we've known for a long time that people, diet is critically important. They shouldn't smoke, and they need to increase their physical activity. That's what my doc tells me every time I go. If I tell him I'm swimming 3 times a week, he says, please swim 5 times a week. when I don't know what's going to happen when I get to 5 times a week. So I think those are key elements for physicians to pay attention to. But we are well aware that, for example, hypertension is not particularly well diagnosed nor well treated. We also know that there remains people with elevated levels of cholesterol that would probably benefit first by lifestyle intervention, and then perhaps by statin therapy. So I think we have more information, but it's critically important for physicians, particularly in a primary care setting, and even specialists to attend to those messages. I know the CDC has just launched a national campaign to get physicians once again to ask patients about whether or not they smoke, and if they smoke, to please refer them to different types of not smoking campaign sites. So I think we're honing the public health message, but we have a long way to go.
Question over there.
Hi, Chris. Nice to see you. Congratulations on the report. Tom Boyke from the Council on Foreign Relations. The question I wanted to ask is the comparison with your work here with the work that you and your collaborators did on the Global Burden of Disease report. And I think one of the great outcomes from the Global Burden of Disease report is that the identification of the lack of data, the vital registration problem globally, the complicated data analytics that were required in that case has really launched this effort to try to get better data in the future. I was wondering if there was a domestic analog to that, and if so, on what issue. The second issue I wanted to ask, related to a comparison to Global Burden of Disease report, is I thought the Institute did a beautiful job releasing a report afterwards on financing that allowed people to look a little bit at the burden of disease as it might relate to global health funding. And I was wondering if there is a similar thought of trying to do something like that in the domestic context.
Thanks very much for both those questions, both very close to my interests. So I thought the data issue, Harvey Feinberg's commentary that's also coming out in JAMA, had a very nice point about this, which was this analysis in the U.S. is incredibly dependent on the investments that the government puts into things like NHANES, the National Health and Nutrition Examination Survey, and those budgets have been progressively cut over a number of years, so that the sample sizes now are getting to be not as big as we really need to be able to track changes. Like, we were just having this discussion about obesity cresting, which is probably true, but if you look at the error bars, because the samples are small, it's plus or minus 3 percentage points. And so it's pretty hard to really know if it's cresting. It probably is, but it's an example where we're quite dependent on the ongoing investments. There are still pretty big gaps in what we know, because we tried to capture everything's in the published literature. We tried to use the wealth of hospital data that we have in this country, of course, individual death records that are multiple coded. We also have tried to use all the national surveys. But for some outcomes, we still find big gaps. Take, for example, something that turns out to be really important is the musculoskeletal disorders, where there's been periodic special supplements in the National Health Interview Survey. But compared to many things that are big causes of burden, like ischemic heart disease, our knowledge is much more limited. And so in some ways, you could go through the 1,000 outcomes in the study and map to where you could almost give a quality score about what our information system is telling us. But you'd have to give a general view that we have a lot of knowledge at the national level. If you go the next step, which is what I strongly believe we should be doing as a nation, which is tracking this sort of comprehensive scorecard by community, by state, or by county, or by city, then we run into huge issues that we don't have a subnationally representative survey that measures blood pressure, as an example. We have self-report through a telephone survey, but that's very problematic because of underdiagnosis of blood pressure. So as soon as you go below the national level, there's some really big data gaps. which hopefully, as people get motivated to track these outcomes, maybe there'll be a demand from government. And you see some local governments, New York City, some state governments that make their own investments in richer data collection. The comment on money is exactly the sort of idea that we think we should be heading for, which is if you can relate how much we spend, maybe nationally across countries or even within the country, even better, on a specific disease and to burden or some metric of the outcome, you can start to examine why some places spend little and get good outcomes. Now, that may not be related to healthcare, but it may. And we may be able to identify where there's mismatches between dollars and disease burden. My favorite example, even from some preliminary work we've done at the national level in the US, is cellulitis, where we have something like 3 million bed days of hospitalization for cellulitis. And there's not really much published that says you need to hospitalize for cellulitis. Little examples like that. If you had that by locality, spend by disease and injury and outcome, I think you would open up a completely different conversation in this country about very granular, specific opportunities to look at where dollars go and how we might get more value for money. So that's very high on our agenda. In the ongoing burden of disease that we're now funded to do across countries, adding that component of expenditure by disease is part of the plan.
Just a brief follow-up was the mapping of Chris's project with non-communicable diseases, which has now become part of the UN's agenda, I think is an ongoing initiative about how they map. The other issue that came up in our review is that the dietary data from the US and some of the OECD countries is excellent. And so the comparison within the U.S., the 1990 to 2010, the risk profile that Chris articulated about dietary risk versus disease and disability in the U.S., we think there's tremendous validity in those data. I think there's greater concern when you begin to do country-to-country comparison because of the quality of the data from all 34 countries is not the same.
Certainly. Question here?
Hi, Matt Haldane from Reuters. I'm wondering about your thoughts on obesity being identified as a disease, whether that would happen, or whether, since caloric intake is a big driver, whether that's not something that's being looked at or likely to happen.
So I think Howard will have comments on obesity as a disease. I just want to note that obesity is already listed in the International Classification of Disease and Injuries, which is the disease classification and nosology that the WHO maintains, and it's been there for quite a while. So we've always had it there as a disease code. It's just not often used as the primary diagnosis for individuals. But I think you'll be in a better position to comment on the U.S. changes.
Right. You may be alluding to the American Medical Association at their national meeting a few weeks ago endorsed that obesity be seen as a disease and be coded as a disease by physicians. I think Chris is right. It's always been available. The AMA is one of the leading professional groups that speaks on behalf of not all physicians, but some physicians, quite a few. And so I think it was a very important statement. I've seen the internal data. It was probably the most picked up news story that the AMA has released in close to a decade. So I think it rung true to how the public is beginning to think about obesity. You always worry about labeling. On the other hand, I think there's some benefits by being clear with a patient that this is a disease. It may make people pay more careful attention to what they need to do better with respect to their weight. But it's always a balance. It's a sensitive issue, particularly around children. You always worry about labeling. On the other hand, I think it was a very powerful statement for the AMA, and I think it's hopefully it will continue galvanizing both the public and the medical community about the need both to pay attention to obesity, but not just obesity, but our entire our entire dietary patterns of eating in the United States.
Oh, sorry. I don't know who is next.
So-
Here, there.
Hi, David Pittman with MedPage Today. My question has to do with the life expectancy of women and how in a great many counties it has gotten shorter. Do you think this is the case? There's mentioned earlier the use of tobacco, but I'm wondering if you can kind of expand on not only the significance of this, but why you think this is the case.
Well, I think what we know is that life expectancy hasn't improved over 25 years in about 40% of counties. There was a period from about 1993 to 2002 where life expectancy actually dropped for a number of counties in the U.S. And in the more recent 7-year period, we don't see that. There's a handful where it's dropped, but many fewer where there's a decline. But overall, there's a 25-year period where 40% of counties in the U.S., there's no progress. In contrast, there's only about 5% of counties in the U.S. for males where there's been no statistically significant improvement in life expectancy. I don't think anybody can give a precise answer as to why, because that sort of community level rigorous analysis has yet to be done. And the challenge there is to be able to do that, you need county level measurements for all the key determinants. We know it for education and for income, but what we really need is to put all the evidence together on the big drivers like tobacco, obesity, et cetera, and then put it into the analysis of what trend is. And I think that's work that's ongoing. Interestingly, the things that are easy to measure, like change in life expectancy versus change in income or change in education, don't explain very much of what's going on. So yes, there's this incredible relationship that we know between poverty and health, but at the community level, what's driving these changes, these huge differential changes where some communities see big increases 6, 7, 8 years for women versus no improvement, doesn't turn out to be currently related to changes in income and education. But I think we'll have to wait to get a more definitive answer on that. Those preliminary types of studies suggest that tobacco and obesity do seem to correlate. And that's all it is at this point. These are sort of correlations that help us understand that. Here.
Keith Martin, the Consortium of Universities for Global Health. Chris, this is a gold mine for public health agencies across the country. In this work, did you aggregate public health or primary health interventions that have been used in areas where there's been a significant decrease or improvement in health outcomes? Have you aggregated those good or best practices, things like the Naperville school example where 40 minutes of exercise a day had a dramatic change in outcomes for children?
So no, the answer is we haven't, because we haven't. I think what we see is this sort of evidence, whether it's at the national level or these sort of county level patterns, as documenting what's happening in the world. And then there's another level of analysis and exploration to sort of trace why, the sort of how did this happen type question. And we hope that that's both something that the media does, but also what the policy research community may pick up. And that takes quite a bit of local knowledge, because it's not simply about running a regression and a statistical analysis. It's also about understanding what was the context by how a particular program got implemented, and why is the same program that sometimes we see implemented in Kentucky for physical activity very successful, and maybe a similar effort somewhere else wasn't. So there's often a little bit more than just identifying the policies. But we hope this provides the sort of catalyst for people to work on those questions.
We found out a couple of days ago that Mexico surpassed the United States in obesity levels. Is there anything that you found in your research that showed that this was coming? Is Mexico getting more obese, or are we getting healthier? Is there a mixture of both? Is it too hard to tell? Can you talk about Mexico and the United States a little bit?
Sure. And here's a little bit of inference around Mexico. Let's go back to 2001. And watch the Texas border as the changes in obesity. You will see that there is quite a substantial increase in obesity levels around the Texas border. And we know from the 3 series of national surveys called Ensanut in Mexico, which is their equivalent of NHANES, the National Health and Nutrition Examination Survey, their version there, that obesity is steadily rising. Now, obesity is going up all over the world, and it turns out from the Global Burden of Disease study, it is not the highest in Mexico. In fact, the highest levels of obesity that we see in the world are in a series of the Pacific Islands, Tonga, for example, or Samoa. And then the next highest levels we see are in the Middle East and in South Africa. So Saudi Arabia, as an example, the Gulf states have extraordinary levels of obesity that even surpass ours or Mexico's. But there's a very high level and a rapidly rising level in Mexico as well. I think I'm getting the signal that we should wrap up soon because we have to move. One more question, if there is one. If not, perfectly timed signal. Thank you very much. Good team there. All the hard ones go to you.